Welcome back to the Girl Doc Survival Guide. Today, I'm very pleased to be with Dr. Lisa Sanders. Dr. Lisa Sanders, MD, is a professor of medicine at Yale School of Medicine and medical director of Yale's Long COVID Multidisciplinary Care Center. She is widely recognized for her interest in diagnostic medicine. She writes the long-running Diagnosis column for the New York Times, which inspired the television series House, for which she also served as a consultant. She's the author of Every Patient Tells a Story, Medical Mysteries in the Art of Diagnosis, and Diagnosis, Solving the Most Baffling Medical Mysteries. A graduate of Yale School of Medicine, where she completed her residency and served as chief resident, Dr. Sanders previously had a distinguished career as an Emmy Award-winning producer for CBS News. She brings a rare blend of clinical insight, narrative skill, and investigative rigor to the art and science of diagnosis. Welcome to Lisa.
Thanks, Christine. It's nice to be here.
Can you first talk about your career journey?
Sure. My first career after college was in television news, which I loved. I loved because you could ask people anything and they would tell you. They would answer your questions. I've always been a very nosy person, and so this really satisfied that part of me. But after a few years, I realized that television wasn't really the right medium for me. I wanted something different. If you don't mind, I'd like to tell you a story about how I decided to become a doctor. When I was at CBS, I was producing a doctor named Dr. Bob Arnott. He was a specialist in sports medicine and loved sports. A lot of the stuff we did together was about different activities that were outdoors. And we were down in North Carolina and rehearsing for an episode the next day where we were going to be live. He was going to be coming down these river rapids. And we were practicing it so that the cameraman could make sure the sound was all right. And suddenly, Bob just disappeared from the tiny monitor I was watching him on. I looked up and couldn't see him. And then I finally saw him. He was on the bank of the river, pulling this elderly woman out of the water. And then he did something that I'd really only seen on TV. He did CPR. And after a minute, maybe less, she turned her head and about an entire ocean of water came out of her mouth. Then she sat up and he was fine. And I thought to myself, if I say it in television, the chance that I'm going to save somebody's life is really small. Up until that moment, I didn't even know that I wanted to save people's lives. But it turns out I did. Eventually, I decided to go to medical school and came to Yale and have just stayed here ever since. There was a moment in the first year of medical school when I was in a classroom for 6 hours a day, surrounded by 99 colleagues. I thought, really? Can I do this for 2 years? Just sit? Once I got to third year and saw patients, went into the hospital, got to do things. That was exciting. And I knew that I had come to the right place.
That's cool. Yeah. I feel like it's not easy to switch careers. So it's really amazing that you did that. And also still continued with your journalism in the sense of the diagnosis column and your involvement with the House series, which I loved. I loved that show.
Me too.
You have this long-going interest in diagnosis and baffling cases. And have you learned something about how physicians, whether early or late in their careers, can avoid cognitive bias?
The awareness that you could be wrong has to always be present. We sometimes forget that because we're usually right. Common things are common and we're often right. But what I teach residents when I work with them in the hospital, I teach them that before they send me their note, they have to have at least 3 possibilities. They must have a differential diagnosis. We have to keep an open mind. I think that so often we forget this. And I think we're much more likely to forget it as experienced clinicians and as new clinicians, where the fear of being wrong is certainly for me so intense. And I was so worried about missing something. Now, frankly, I'm much less worried about missing something, which makes me worry that I could be missing something. But when I'm in the moment, it's hard to remember that I could miss something. I now run the long COVID clinic. Very early in my tenure at the long COVID clinic, I made a diagnostic error. I saw this woman. She was in her 40s. She came in and she said, I have POTS. POTS is postural orthostatic tachycardia syndrome. She said, I just want you to help me manage it. So I just accepted her diagnosis of POTS and didn't do the basic tests that I do for people with POTS because she came in with a diagnosis. I treated her and she called me after a couple of weeks and said, I don't feel any better. I'm like, oh, okay. I had just taken her diagnosis for granted. So I said, well, let me send some labs because I immediately thought of all the other things that can cause this kind of tachycardia. And sure enough, she had hyperthyroidism, which hadn't been diagnosed by her primary care doctor. And she'd been sent to me with the diagnosis of POTS. One of the only things from Ronald Reagan that I have ever quoted, trust but verify. And I forgot that. And I sent her to an endocrinologist and she's doing great. Her image haunts me even now and helps me remember to think more broadly because because a patient's doctor has said that this is what they have, you have to make sure that's right.
Yes. I appreciate that story as well, because I think you're right that earlier on when we're newer and closer to training, you remember all of the rare things that you've learned. And then progressively, the longer you are in practice, common things are common. And most of the time, not correct to be thinking of the rare things. Most of the time, they don't have the super rare thing because it's rare. But every once in a while, they do. And I think it is really hard because we're often time pressed. And the longer you are in medicine or in a career, you're often more time pressed, not less time pressed.
In terms of the time, we doctors collaborated with our employers to make us time pressed. We don't have to be that way. And whenever I speak to doctors, I encourage them to rise up and rebel and get more time.
I like this. Can you expand on this?
When I started this clinic, I was very clear about what I needed. I said, I need an hour with my new patients, period. So I got an hour. I don't know that they were happy to give that to me, but they gave it to me. All follow-up patients get a half an hour. And so then you have time to really listen to people and address their concerns. And a lot of times, one of their concerns is other doctors don't have time to listen to me. That's probably the most common complaint that's not about their physical well-being that I get, that doctors are too hurried to get a full history. And research shows that they're not wrong. Most diagnostic errors happen while the patient is right in front of you. And if you don't have time to get enough information, you're going to miss things. If you care about making sure you address your patient's needs, and getting more time is important. The older, the more experienced you are, the more power you have, the more leverage you have. I learned this from lots of doctors at Yale. At Yale, there's a tradition of doctors practicing into their 80s. And I noticed that some of the senior doctors just had more time and were able to decide their schedules. And I don't know why other people can't do that as well. Replacing a doctor is a very expensive proposition. And so we all have some leverage. One of the ways you get to be a doctor is that you're compliant. So you do the pre-med that they ask of you, then you do medical school, and then you do residency where they ask you to do all sorts of crazy things. And so this whole tradition of just knuckling under to authorities is built into how we're formed. And so that makes it much harder for us to stand up for ourselves. It's ceded control. And I think we should take it back.
Being somewhat obedient, that's the way you become a doctor. And people pleasing and an inability to say no. Also, I've seen my colleagues, sometimes it's that they feel like they're the only doctor. Of course, right? There's many doctors out there.
We all think we're the best doctor.
There's this feeling of the person needs to be seen right away. And so who's going to do it other than me?
If you had room in your schedule for that, then it wouldn't be a problem.
Yeah.
All these things can be addressed, but there has to be a recognition that this is a problem and then a desire to change it. If we had control, we would be able to be more flexible. But we've ceded control. I think we just have to take it back. There is a risk that doctors will be replaced by PAs and APRNs for primary care when they have complicated patients. PAs and APRNs will be the first to say that they would refer them to internists. If there was something that was complicated, you would refer it to an internist. To me, that makes a great deal of sense. I think that there's a better way to do it. We're just not doing it that way.
That's cool that you have an hour with new patients and 30 minutes with return patients. It sounds like you are able to really listen to the patient. So I guess one way that busy clinicians can try to listen better is to create more time, as you have done, put their foot down and demand, okay, I need X amount of time with a new patient versus a follow-up patient. They can do that. Having listened to patients over the years, is there something that's taught you about the patient experience of not being believed?
Yes, it's still an ongoing thing where patients have a hard time being believed. I never saw a patient with POTS while I was a resident. Nobody ever mentioned that diagnosis to me. And I'm certain I saw it, but didn't recognize it until I came and started this clinic and started reading up on what people with long COVID had. And the same for MECFS, myalgic encephalomyelitis, chronic fatigue syndrome, or brain fog. We don't even have a good name for brain fog, and yet it's probably the second most common problem in long COVID. I had to figure out how to take care of these patients.
It's hard to recognize something when it doesn't exist until finally recognized.
Actually, I would say that post-infectious syndromes and long COVID is just one of many post-infectious syndromes. These things aren't really new. They haven't been identified because there's no test.
Yeah. So it's partially then, since post-infectious syndromes have been around for a long time, it's just that it comes back down to that women in general just aren't really believed when they come in with their symptoms.
Maybe. I think that's historically been true. I hope it's not still true, but it probably is. Women have very complicated physiology. We have periods and menopause, all kinds of changes. Because of this sort of complicated background, I think it might be harder to identify low-grade illnesses. These are symptoms that are like, I'm tired. Fatigue is the number one complaint of the patients that I see. So fatigue, okay, let's make sure you don't have anemia because younger women bleed every month. Let's make sure that you don't have hyperthyroidism because women are more likely to get autoimmune diseases. You have this list of things that you want to rule out. When you rule out all those things, what do we end up saying? You get more sleep. Sleep is important. I'm the first person to say that, but that's not the answer. There are other possible causes of fatigue that have to be considered. You have to think more broadly about what causes fatigue and be informed about post-infectious syndromes, undiagnosed sleep apnea, chronic fatigue syndrome, which has its own diagnostic profile. For those people, stimulants are not good. This chronic fatigue syndrome is characterized by post-exertional malaise, where they're so tired they can actually not get out of bed sometimes. And it can last for days, sometimes weeks. They just have to figure out how to pace themselves. We say sleep more and get more exercise. These are not therapies that can treat chronic fatigue syndrome.
Yeah. Diagnosis can get so complicated, right? It's part of the fun of it. But
This part of it.
Since you did pivot in your career, do you have any advice for people contemplating a nonlinear career path?
It will work out, but it's important to have support. I could have never done this without the full-throated support of my husband. I left an extremely well-paying job. Television producers get paid like doctors, only sometimes better. I left an extremely well-paying job to not just not make money, but to have to pay money for the next 4 years. So support in all of its senses is important. And try to identify the things that you would like to have more of and less of in your career. Medical schools have changed so much. Now, medical students interact with patients very early on. And so you can really see how you feel about being around patients, how you feel about medicine from the start.
Yeah. Do you have any final thoughts?
The great thing about medicine or going to medical school is that you can use it to do anything you want. for many people, it can be a wonderful profession and exciting and interesting and flexible.
Thank you so much for your time. I really enjoyed hearing your stories and your thoughts and the advice to rise up and make it.
Please. And when you start the revolution, call me. I'll come and help.
Sounds good.